Hello, you're listening to HFMA Talk, the podcast for NHS Finance. I'm Sarah Day, Policy and Research Manager at the HFMA. In this episode, we listen in on a conversation between Sandra Easton, Director of Operational Finance and Performance at NHS England Improvement, and Marcus Thorman, Chief Financial Officer at the Royal Marsden NHS Foundation Trust. The national response to Covid-19 had to be swift as the scale of the pandemic became clear. Sandra and Marcus discussed the thinking behind the approach to simplifying NHS finances during this period and what this meant for those putting it into practice. No part of the NHS has been untouched by the pandemic, and there has needed to be quick but sound decisions made across the system. Good financial governance has therefore been imperative, and the conversation goes on to discuss the practicalities of maintaining effective governance in challenging times.
Hi, I'm Sandra Easton. I'm Director of Operational Finance and Performance for NHS England Improvement.
And I'm Marcus Thorman. I'm the Chief Financial Officer for the Royal Marsden Hospital. Okay, so Sandra, you've been at the centre of the recent financial decision making at NHS England Improvement. What was it like in the early stages as the scale of what we were facing became clear?
I guess like for many people working out in the service, the scale of what we were facing, we saw in the news what was happening around the world and the scenes from other countries that had been impacted weeks before we had. And we started to realise that actually this could be something quite significant. And as the number of cases and hospital admissions in the UK started to increase, we started to realise the impact that it was going to have on our normal operations, the way that we normally conduct business. And first of all, we thought, we might see an impact on our non-elective services, and we might have to have a plan for what would happen with our elective care. But actually, within the space of a week or so, we realised that was not going to be possible. The wave of infections that we were seeing across the country, with the hotspots spread out geographically, would mean that we would need to make some significant and fundamental changes to the way we ask the NHS to do business to deal with that. And that meant having a look at the entire financial architecture of the whole system. There would not be a part of the system untouched by COVID-19. Whilst, for example, specialist hospitals like the Marsden, you might think as a cancer centre, would be unaffected by COVID. When you're looking at it as a potential pandemic, when it actually hits as a pandemic, you realise that it is going to hit everyone, even those services that you thought might be quite isolated. So that's how we came up with an idea of needing to do something quite fundamental, and that was where we started thinking about what could an interim financial regime look like.
Brilliant. So what were your considerations in helping to design this new system?
So we wanted a system to be as simple as possible. One of the reasons for suspending the old financial architecture was just the complexity and the time that it took to do it. So we could have continued with a cost and volume based funding mechanism, but at the beginning we didn't know what a typical COVID patient would look like. We didn't know what their patient pathway would be. We knew that we would have to switch lots of our activity to non-face-to-face. Not everyone would have a way of counting that, of coding that. So we quite quickly realised that the traditional cost and volume contracting that we have in a lot of the acute sector, for example, was not going to be sufficient. Added alongside the impact that we were starting to see in our elective activity programmes, we realised quite quickly that we needed to go to some sort of block payment funding. We needed to think about how we would construct that really, really quickly. So we had to tell systems to pause planning, to pause contract negotiations, but we had to very quickly come up with the alternative. to fill the void that pause created. So we wanted to design a system that we could manage from the centre nationally as simply as possible, but that would cover 90% of the issues and the concerns that would be out there in the system, both for providers and for commissioners. So that was how the block came about, and we decided, so going into a pandemic, we would need most of our beds, if not all of our beds, open, and we would need to staff up our resource to the level that we would normally during the winter period. So that's why we decided to have a look at our winter cost base as the indication going forward. But then we knew that there would still be more costs over and above that driven by COVID and the type of virus that it is. So we expected to see huge increases in the costs of PPE, for example. We expected with the need to socially isolate, socially distance and quarantine, that we would see an increase in the number of staff unavailable to work, and therefore there would be additional costs related to that. So we needed a mechanism for catching that. But what was forefront at our mind at the time was how do you maintain financial governance in that situation, because it's a very fast moving position, especially if you're a frontline organisation and you have got patients coming in your front door that you're not used to having in the volumes you're not used to having. You're having to create additional ITU capacity, and you're having to be very reactive. How do you, on the front line, maintain financial control and financial governance, and how do we at the centre explain to you what the current rules of the game are in such a way that allows you to do that? So that was why I wanted to have a conversation with you, Marcus, about what it felt like as a CFO on the front line when it started to become clear the scale of what we were going to be facing.
Yeah, so I think like you, early on you could see what was happening across the globe, and it became particularly pertinent for the UK when you could see what was happening in Italy, and everyone was looking to Italy and saying we're 10 days behind, a week behind Italy's response. So you knew the direction it was going to go in. And we, as a system in the hospital, but also across the STP as well, set up quite quickly with a command and control structure, which had a daily rhythm to it. And initially that was just Monday to Friday, but we quite quickly stepped that up to weekend working as well. And although we weren't a general admission area for COVID positive patients, because they would go through the acute hospitals, obviously we know that those with comorbidities and particularly cancer patients do particularly poorly with COVID-19. So we went through the same structure and response within the trust as any other acute hospital or any other that I've spoken to has gone through. And although the number of patients that we've seen that are COVID positive has been a lot less than perhaps what was going around in the system, what we found is those that came into the hospital were particularly poorly and were therefore straight to our critical care unit. And initially it was just that anticipation for when we would have the first patient, and then the first staff member that we'd got tested that had got it, and et cetera, and there was just all of that nervousness in the organisation. But also a sense of, look, we've got to step up to the mark and deliver upon this. So I very quickly moved from being finance director to 50% of the week responsible for the command and control centre. And so using a completely different set of skills that you learn on financial training, but demonstrated that it didn't just need to be clinicians that were running the command and control centre, that those that were outside of a clinical background were more than able to run those centres.
So the 50% of your time that you actually got to spend as a CFO, what were the first sort of challenges on the finances that you started to see?
So I don't think you ever stop being a CFO, even in the command and control structure. For me, one of the early things that we did was we recognised that people were asking, can we do this, can we do that? And a lot of the additional can we's had pounds attached to them, and that there was a responsibility to make sound decision making, but at a fast pace. We couldn't wait around and have the normal process of review that we would have on such things. So we very early on, we looked at a set of updates to our financial governance and a change to our SFIs, which I can come on to later on. But it was really understanding and making sure that we had control whilst not slowing down the organisation in its decision making. And so we made an exec director, whoever was responsible that day was able to enact the decision making that was normally referenced for myself or the chief executive. So we just slightly adapted the governance, but what we made clear is that any decisions, whether it be via a text, whether it be via an email, whatever, needed to be kept for audit purposes. Any decisions that we made, it was really important that it was clear who made the decision, and at some future point we would be having to come back to those decisions to justify the expenditure that was going through the system.
That sounds very much like how you would record decisions in a major incident. Was that the approach that you took to the initial days of financial governance?
Absolutely. So all of the decisions were, if they were above a certain limit, so we put in 100k, if it was below 100k, then a director could make that decision outside of the daily rhythm of the command structure. But if it was above 100k, then we would take it to that daily meeting and have that discussion there. And you have sort of 40, 50 people on the call, a range of individuals, and then the decision would be made there and then on that basis.
So you mentioned that you adapted your SFIs and put in some temporary financial governance. Do you want to talk me through the sort of changes that you put in place and how it worked?
Yeah, so the key change was that within hours, the director responsible for the command centre was able to make that decision. Out of hours, we had the normal on-call arrangements, and again, a director would be responsible. So that may be a different person during the day versus the person who was on call for the week, because we kept with that same on-call arrangement that a director would be on a week at a time. So that was the initial thing that we did. We also made clear that for a lot of procurement was spent, the team in procurement was spending a lot of time sourcing PPE and other stuff. So the business as usual on contract renewal, etc., was really difficult to be able to maintain that business as usual. So one of the things we did was we did a lot of extensions to contracts that were in place, and a lot of them finishing at the end of the financial year. We would say, right, let's just roll forward for a 3-month period on the same terms and conditions. And so we did a lot of that as well. And then in terms of capital, because normally all of our capital goes through a very strict process in terms of approvals. And again, capital, we made sure we didn't have huge amounts of it at the beginning, and we haven't had anything that was greater than the sort of limits that had been set centrally. But there were a number of items that we needed to make quick decisions on, and again, those were done fairly quickly with regards to that. Then the overall governance itself was a tweak to the SFIs. And what we did was we got that written up. We're accepting that there was no budget in place for this, and so the rules were very, very different. But what we made sure is that, first of all, that updated guidance was then shared with our internal auditors. They quickly, within 24 hours, they returned and gave us some added thoughts with regards to that. It then went to our audit committee chair, who again, within a few hours, responded, and then we took it through our board. We just happened to have a board at that time as well. So it went through effectively our internal auditors, our audit committee and the board, all within a period of about 48 hours, which probably is unheard of in the NHS. But everybody accepted that this is what needed to happen. And then I shared the document across South West London as well, because I think we were perhaps slightly ahead of the game in terms of that type of thinking, and so I shared it around South West London for other organisations to tweak and add to, etc., etc. And I think one of the great things that's come out of this process at the moment is the sharing of documentation across organisations and across STPs that have helped organisations not reinvent the wheel, but it effectively gain from other people's knowledge, which I think is really helpful. We've gained from other stuff from other organisations.
So that's really helpful, and understanding how you adapted your processes and your systems to deal with the time pressures that COVID has created is really, really helpful. One of the biggest things for me, though, is how can we, as finance directors, during a clinical incident, bring the right level of challenge and discussion to those processes. So how did you tackle that at the Marsden?
So I think that comes from in reality, there shouldn't be that much difference apart from speed, and there shouldn't really be that much difference from a normal day-to-day process, in that I think we've got a relatively good system in the Marsden. Obviously, there's always improvements that you can make in terms of the governance that you have in place. But generally, the organisation knows that for additional expenditure, they need to either write a business case or go through some governance process of getting additional expenditure. And all we did was accelerate that. So we weren't expecting people to write a business case, but being able to fully justify verbally in a meeting the rationale as to why they wanted what they wanted and what they wanted to do. And as long as it made some sort of credible sense around that, and again, it wasn't just relying on the CFO to be able to say that makes sense or not. All of our directors, so medical director, nurse director, the chief operating officer and myself as the exec directors would have a sense of this makes sense and we know to proceed with it, or no, that's not what's needed at this time. So there was I think it comes out of a culture of an organisation being financially disciplined in the work that it does anyway.
Right, and you mentioned earlier the need to keep good records and audit. So one of the benefits of having a revised SFIs like you've just taken us through is that it gives a very clear framework that gives a level of protection to officers when they are making decision. But it's only as good as the record keeping. How did you maintain that audit after you moved out of that initial incident into a level of BAU with these SFIs in place?
So it's just very simple things. So we nominated very early on somebody from the finance team that sole responsibility was recording these costs and ensuring that whether it's capital or revenue, that everything filtered through an email address that picked up all the COVID costs. So anything that I saw or my director colleagues saw that had that, they knew to copy in this email address. That was set out in the governance that we had. We tried to keep the document down to just a few pages so that we could ensure that people read it. We didn't want it just to be in an email inbox and never actually read. And from that basis, we know that we've pretty much picked up. There'll always be something that goes through that slips the net because somebody didn't know about it or wasn't aware in terms of that. But generally, we found that I would say 95% plus of that expenditure has gone through. And when I forwarded something on, because I've seen something, then the team have told me they've already seen it. It's already been sent through to them. And because we've got that daily rhythm of the sort of 40, 50 people who were on the call, they knew that to pick up any expenditure related changes, that was the process. So it was drummed into people early on a daily basis. Look, any additional costs, then we need to put that through and make sure that was picked up. Similarly though, how would you, Sandra, so you must have felt the same sort of pressures in the national team. What did you make sure that you've got the right levels of financial governance and control in place from lots of different organisations all requesting various different things from you?
Yeah, I mean, it's interesting because we've got two bits of complexity, because what we have to do is we have to make decisions for ourselves as an organisation. So we had to put in some revised SFIs, for example, and business processes for all the things that NHS England Improvement would want to fund or need to do as part of the COVID response. So we had to stand up a whole new framework to be able to make business critical decisions within 24 hours in a similar way that you described there, Marcus. Our SFIs were very much wedded around where you have agreed budgets in place and people's authority against those approved budgets. Well, we didn't have a budget for COVID, so we had to very quickly put in place a framework that enabled our regions and our national directors and other colleagues to apply for funding, to submit short business cases instead of going through the longer routes that we would have had traditionally.
So, Sandra, you mentioned capital and having to speed up the decision-making process around approvals. What did you do and how did you go about it?
So it became clear to us within sort of a week of us redesigning the financial architecture that actually the response to COVID is going to require some significant changes to our infrastructure, be it the physical estates or the digital infrastructure, and that we would need to set up a form of governance around capital approvals for the system. So what we did was I have a team that work for me, business case assurance team. So that's a team of 6 individuals who, capital business cases is their business, it's their bread and butter. So we took that team and very quickly stood them up to be the COVID capital team. But we had to significantly change their focus because this wasn't about doing a 5-case model anymore. This was about getting sufficient information to national decision makers to allow capital bids to be approved within 24 hours. There are so many things that we have learned over the last few weeks around the types of capital, the drivers of the decisions that we need to make, that we have tried to be as adaptive in our processes as we can be. Now we're moving into the second phase of COVID. We are taking a bit of a pause to really understand what the slightly longer term capital requirements to the response are going to be, and taking the opportunity to get those plans joined up at a regional level so we have a good view for the next 12 to 18 months how each region, how each hospital is going to adapt and change to deal with the challenges that COVID, alongside business as usual, is going to pose for the future.
So we've made a lot of changes, or the system has, both locally, regionally and nationally. Are there any changes that you've made at the moment that you think you would like to keep for the longer term?
So I think there has been some fantastic changes in every single area that you look at that has stood up a response to COVID. Be it, the digital outpatients that, was a tiny proportion that's now ballooning to the engagement that we see at STPs, really bringing together what system healthcare is all about. From my perspective and the finance perspective, it's been great that we've been able to fast track some of our decision making, and trying to keep some of that will be really good. we're not going to be able to keep a 24-hour approval of capital business cases, but actually we can really learn from what we've done and the processes that we've stood up and the questions that we've asked. From a revenue perspective, I think we have a golden opportunity to think about doing something different. And I'm really keen on engaging with the system and finance directors like yourself, Marcus, to co-design what we think the right answer will be. We think COVID is going to be with us for a little while. What does that mean for the financial architecture of 21-22? We don't know, but we need to come up with a solution. And for me, that's a solution that we co-designed together. But I was going to ask the same question of you, Marcus. So what within your organisation are you hoping to keep? And what are you hoping to see maintained on a wider perspective?
So I've heard a few people say, let's not waste a crisis. And I get what they mean with that, because there has been a whole load of things that have stepped up that we would have thought would taken years before to get enacted. And you've mentioned one, which was I was going to mention too, which is the digital outpatients. We've seen significant change in the way that we in the organisation do it. We've seen our MDTs transformed, and one of our clinical leads within the organisation said the other day, there is no way we're going to go back to the old way that we did MDTs, because there was often difficulties in doing the MDTs across the whole of Southwest London, with organisations being able to dial in or not being able to dial in. Now we're doing it through Zoom or Teams, and they're able to share and see the information. And so I think that will transform the way that we do cancer care into the future. So there's those sorts of things that we absolutely need to keep and make sure that we've got the benefits on. Likewise, I don't think that we will be making business case decisions in quite the speed that we've had to. We will need to take a bit of a longer time. Not that I think we've made any particularly poor decisions with regards to increased expenditure that we've made, but most of it was the barn door obvious that we had approved, and it wasn't that difficult to either say yes or no to, and therefore I think what we'll need to have an understanding of is the longer term financial architecture. I know you're doing a lot of work at the moment looking at that, but we've obviously now, it was announced at the end of last week that we've got the block contracts extended till the end of October now. It's thinking about what the next stages will be with regards to that, what the next stages will be in terms of the capital regime, and being able to, what's really impressed me is the information that's come out from the centre at a quick process, and being able to enact upon that really quickly. That Julian and yourself and others have done some great webinars that have, even when there has been a sense where actually there's not much more we can tell you, it's just being able to describe to us what's going on, and being as candid as you have been with regards to that. That's been incredibly helpful too. So I would hope that things like that will continue. And being able to collaboratively work on what the financial architecture and what the financial governance will be into the future, because I think there's a lot of organisations that can help with that as well.
So Marcus, COVID-19 has presented lots of challenges for organisations and for the workforce. Talk to me about what the impact's been on your finance team and how they've adapted and how they're dealing with the new pressures and the unknowns that they're facing.
Yeah, so as you know, Sandra, I look after finance, IT and estates, and each of them have got different responsibilities, obviously, but you can't have an electrician working at home, for example, whereas our IT and finance teams have been able to work at home and have been digitally enabled to do so. So there was a massive response differential between people. I think, like everybody, there was a number of people that were really nervous. and really quite scared, I guess, about the unknown. And so we were able to step up within the organisation some of the talking therapies to assist people to access that. And I don't know if my teams have accessed it or not, but what we've been able to do is put on those resources and people can access them anonymously. What we also found is that that there has been some fantastic things with regards to Teams and Zoom meetings, etc., that have really helped keep in connection. But you don't quite get that just passing somebody in the office and have a quick conversation about something. You don't tend to Teams for those sorts of things. And so we need to think into the future how we want to change that and how we utilise the tools that we've been given, from having people that would work from home maybe once a week from within some teams to working permanently from home every single day is a very significant change. And I think we need to just take a step back before we start to see people returning into the office and doing things on a different basis. We need to take a step back and say, actually, we've got an opportunity to permanently do things in a different way. And how do we want to make that work? How do we ensure that each of the teams are engaging with one another, having that social interaction that's required to make an office environment work really well, but still manage the social distancing and people being able to work from home and work flexibly. So I'm not sure we've got all the answers at this stage, but we're definitely working on that and thinking through that process. At this stage, I think though that just the ability to step up the working from home environment, our digital team have done a phenomenal job in enabling that through either because there was such a shortage of laptops, we had to do things in a different way. And what we've managed to do is step up a virtual desktop. That means that people can sign on to their actual desktop through a link, a web link from their home PC. And so that has enabled people, without having laptops and devices that can work remotely, they've still been able to work remotely. Sandra, that was really insightful in terms of what you have covered nationally, and really appreciate all that you and the team have assisted with in this period. Just want to thank you and the national team for all that you've done on this.
And likewise, myself and Julian and the whole national team would like to thank every single person working out there in the service for everything that you've done to support the ongoing situation.
All of the HFMA's Covid-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please tell your colleagues. We have also launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section on our website. If there are particular topics that you would like future podcasts to cover, then please get in touch via our email address, policy@hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.